My name is Caroline Blackie, and I am the Medical Director for Dry Eye for Johnson & Johnson Vision. Join me as I review the ocular surface, why it matters, and how we can use new diagnostic and therapeutic recommendations to elevate the level of care we provide to our patients. The ocular surface is a mucous membrane. It is unique in that it is the most exposed mucous membrane of the entire body. In order for the ocular surface to remain healthy, it must remain moist, embody a robust and balanced immune system. It must protect itself from the desiccating stress, pathogens, and irritants presented by the environment. This challenge is unrelenting, especially during waking hours. As such, the ocular surface has built into it a series of specialized tissues which are connected by a single surface epithelium and the tear film which they produce. These specialized tissues are the Meibomian glands, the lacrimal glands, the conjunctiva, and the cornea. The eyelids, which house the Meibomian glands and part of the cornea, are the gatekeepers of the ocular surface. The eyelids directly control the amount of environmental exposure, and through the blink process, they regulate, spread, and refresh the secretions of the specialized tissues. Without the eyelids and the healthy blink mechanism, the ocular surface cannot survive. In combination, the ocular surface and the eyelids are supported by the vascular, nervous, immune, and endocrine systems of the body. When the system is in balance, the ocular surface provides clear, comfortable, stable, and healthy vision. In recent years, we have become progressively more interested in the health of the ocular surface, particularly as it pertains to dry eye disease. In the past, we thought it was a condition that occurred only later in life. Recent data confirm that we are susceptible to dry eye at all stages of life, from the earliest until the very latest. A good question to ask ourselves is whether we have all of the diagnostic and therapeutic tools that we need to manage or potentially optimize the ocular surface of our patients at all of these stages of life. The answer is probably not, but we are making excellent progress. As we work to raise the standard of care that we provide to our patients at all stages of life, we move away from the current reactive level of care to embrace a more proactive approach. We can and should evaluate the health of the ocular surface, its specialized tissues, and the eyelids on a routine basis, and intervene long before our patients report a problem or have their lifestyle choices limited by gradual, undiagnosed decline of their ocular surface health. Let's talk specifically about dry eye for a moment. The challenge of the ocular surface is that it must remain moist. It must protect itself against the desiccating stress of the environment. When it fails to protect itself, the tear film destabilizes and the mucous membrane becomes exposed. If left untreated, a chronic inflammatory cycle ensues, and this cycle can be as damaging as the desiccation of the membrane itself. This process sets the stage for all dry eye, whether it be advanced and present in all contexts, or only sporadically, for example in low humidity and drafty environments, during contact lens wear, or after corneal refractive or cataract surgery. The bottom line is that if the ocular surface cannot protect itself from the desiccating stress of the environment, a diagnosis of dry eye will follow. In 2017, the Tear Film and Ocular Surface Society coordinated a global effort bringing together clinicians and scientists from all over the world to define and refine the diagnostic and therapeutic criteria necessary for comprehensive dry eye management. One of their many goals was to create criteria that could be administered in routine eye clinics all over the world. In so doing, they identified several key criteria for both diagnosis and treatment. Notice the central section of the slide labeled Diagnostic Tests. This section provides clear diagnostic criteria for any clinician anywhere in the world to follow. There are two components to a dry eye diagnosis. The first is to validate that the patient has dry eye symptoms. This is achieved using a known and validated questionnaire. There are several to choose from, designed to assess and quantify dry eye symptoms. The second is to confirm that tear film homeostasis, or its natural balance, has been disrupted. There are 3 tear film homeostasis markers to choose from for a diagnosis of dry eye. These are tear film breakup time, ocular surface staining, and osmolarity. In combination with the validated dry eye questionnaire, only one of these 3 markers is required to show a positive result for a diagnosis of dry eye. Remember that signs and symptoms in dry eye typically only correlate in the advanced stages of the disease, so it is helpful to have proficiency with all 3 of these tests. Let's turn our attention to the last third of the slide. After a diagnosis of dry eye has been confirmed, the next step is to identify the primary subtype or cause of the dry eye. There are simple tests that can be done to identify whether a patient has evaporative dry eye, almost always from MGD, or aqueous deficiency dry eye, from low lacrimal output, or both. The TIFOS JUICE 2 recommendations state that this step must be taken in order to optimize the treatment of the individual patient. The yellow shading on the diagram highlights the fact that the majority of patients with dry eye have MGD. There are some patients who have reduced lacrimal output, the blue shading, and there are some who have both, the transition shading. Typically, MGD and low lacrimal output are only simultaneously observed in the same patient in severe late-stage dry eye. Put more succinctly, the 3 necessary steps with dry eye management are: number 1, diagnose the condition. This requires a validated questionnaire and the ability to test for disruption of tear film homeostasis. Number 2, identify the cause or causes. This requires specific tests for MGD and lacrimal output. Number 3, treat the identified cause or causes. This requires treatment for MGD and or reduced lacrimal output, along with the ability to manage the sequelae of the condition, especially in the short term. Examples of the sequelae of dry eye are symptoms, inflammation, and ocular surface damage. The clinical evaluation necessary to identify reduced lacrimal output requires some form of tear volume test. Tear volume provides a reasonable correlate of lacrimal output. Examples of these tests would be tear meniscus height, the phenol red thread test, or the Schirmer test. The vast majority of dry eye patients will have MGD. MGD is diagnosed by the assessment of gland function and gland structure. Remember that the eyelids, which house the Meibomian glands, are the gatekeepers of the ocular surface. They directly control the amount of environmental exposure, and through the blink process, they regulate, spread, and refresh the secretions of the specialized tissues. An evaluation of the blink and overall eyelid health is crucial for comprehensive dry eye management. Once the cause of the problem has been identified, a treatment plan can be developed. The treatment plan recommended by TIFOS JUICE 2 involves educating the patient as to their condition, treatment for the specific cause or causes, environmental management to control exposure to desiccating stress, and, where needed, treatment to manage the sequelae for the condition, for example, symptoms, inflammation, and ocular surface damage. If a patient already has validated dry eye symptoms and confirmed disruption of the tear film homeostasis, a diagnosis of dry eye can be made. The medical decision-making at this point is reactive. Remember, though, that dry eye and the leading cause of dry eye, MGD, are both chronic, progressive conditions. When we consider that we are partnering with our patients over the course of their lives, the concept of a more proactive approach is very appealing. Proactive management of the ocular surface would include and require routine evaluation of the eyelids and Meibomian glands, the blink, review of lifestyle and existing conditions and medications. Proactively managing ocular surface health not only means that we potentially reduce the likelihood of a patient developing dry eye, but also that we get to intervene early in the disease process when dry eye is easiest to treat. Proactive care also means we maximize the lifestyle choices available to our patients over the course of their lives. Examples of these lifestyle choices are contact lens wear, corneal refractive, and premium cataract surgery. Contact lens wear in dry eye and contact lens wear in MGD have a long established relationship. Dry eye can inhibit a patient from being able to wear contact lenses comfortably, and dry eye can develop subsequent to wearing the contact lenses. Regardless of the timing, this is a clear area where proactive care of the ocular surface could improve the patient experience. Corneal refractive surgery and cataract surgery and dry eye, including MGD, also have a long established relationship. Dry eye can inhibit a patient from being able to proceed with the surgery or from selecting the lens implant that they desire. And dry eye can develop or worsen subsequent to having the surgery. Again, regardless of the timing, this is another area where proactive care of the ocular surface could improve the patient experience. The number of contact lens, corneal refractive, and cataract surgery patients who are affected by dry eye, including MGD, is not small. Recent prevalence data indicate that somewhere between 30 and 60% of our contact lens, corneal refractive, and cataract surgery patients are affected by dry eye, including MGD. In support of this thinking, the medical literature shows a strong trend in the direction of proactive care, both in terms of calling out the importance of identifying and treating MGD and dry eye in contact lens wearing, corneal refractive, and cataract surgery patients, but also in terms of innovating lens designs and surgical techniques to minimize the insult to the ocular surface system. Prior to 2011, MGD was largely diagnosed based on the late-stage findings of the disease. Examples of these findings included symptoms of discomfort, eyelid inflammation, redness, swelling, telangiectasia, gland capping, lid notching, and a few others. These obvious changes reflected the downstream effect of advanced and chronic disease. More recently, the International MGD Workshop recommended that we diagnose MGD early in the disease process, prior to the presentation of the late-stage diagnostic criteria. This approach requires routine evaluation of gland function and gland structure. Gland function can be evaluated a number of ways. They all involve very gentle pressure placed on the eyelid over the Meibomian glands. Using the Meibomian gland evaluator, you can standardize the amount of pressure applied to the glands. This allows you to generate data that can be readily used to track small changes in gland function over time. You can grade the secretion quality using a numeric scale. Gland structure can also be evaluated in a number of ways. One example would be to use the LipiScan with dynamic Meibomian imaging. This offers multiple methods of imaging the glands, which all result in a high-resolution image of visible Meibomian gland structure. Once an eye doctor has made a diagnosis of MGD, they advance with the treatment plan. As with most chronic progressive diseases, a staged treatment approach facilitates targeting the core disease component along with incorporating adjunctive therapies as needed, depending on the severity of the case. With MGD, the primary mechanism compromising gland function is stagnation of the gland contents, leading to gland obstruction. Addressing the stagnated gland contents is a critical step in any MGD treatment plan. Once the stagnated contents have been addressed, various adjunctive therapies can be added to support the ongoing management of the patient's MGD and their symptoms as needed. We now have some clear recommendations for how to diagnose and manage dry eye. We recognize that MGD is not only the leading cause of dry eye, but also that it is relatively easy to identify and to treat, particularly in its earlier stages. A proactive approach facilitates early intervention and reduces the likelihood that the ocular surface might limit a patient's lifestyle choices. All of our patients at every stage of life need the clear, comfortable, and stable vision that only a healthy ocular surface can provide. We look forward to a future where we continue to innovate and integrate ways to routinely evaluate the health of the specialized tissues of the ocular surface, the single surface epithelium connecting them, and the eyelids, the gatekeepers of the ocular surface. It is an exciting time to be in eye care.